central nervous system infections. Okay. So mainly, just as overview, central nervous system infections we are classifying based on two ways. Many classifications are there. Okay. Number one is based on the structure. One is meninges. Second one is brain tissue. And the third one is spine. This is based on the structure. The infection may be either in meninges, or the infection may be in the brain tissue, or the infection may be in spine. Next is based on the etiology, based on the organism. So everybody knows the common agents are bacteria, both conventional and non-cultivable bacteria is also there. Next is virus and fungi. Do not forget parasites. So the CNS infections are classified. One is based on the structure, another one is based on the this one. Okay, right. Next is some definitions, some basics. Okay. One is called meningitis. Very simple. Infection in the meninges, the covering of the brain. You know that. Number two, encephalitis. It is nothing but inflammation of the brain tissue, brain parenchyma. Inflammation of the meninges, meningitis. Inflammation of the brain tissue, encephalitis. And inflammation of the spinal cord is called myelitis. So we need to say which structure is involved. We can call it as meningitis, encephalitis, myelitis. Suppose in case of meninges and the brain parenchyma involved, we call it as meningoencephalitis. Or all three are involved: spinal cord, brain parenchyma, and the meninges. We call it as meningoencephalomyelitis. Meningoencephalomyelitis. Okay. So this is based small classification. One is based on the structure, another one is based on the organism. Okay. Now, based on the organism, okay, we are going to discuss today mainly meningitis. Today we are going to discuss mainly meningitis. These meningitis we are classifying based on the duration. One is called acute meningitis, abrupt onset. If it is prolonged, present for a long time, we call it as chronic meningitis. So one is acute, another one is chronic. In the acute meningitis, again we are classifying. One is called pyogenic meningitis, mainly caused by bacteria, mainly, and some fungi also. The polymorphonuclear cells are predominant in this condition. One is called pyogenic. One is called pyogenic meningitis. Okay. Another one is aseptic meningitis. pyogenic meningitis. Another one is aseptic meningitis. Hello, Dr. Dhruvel, Dr. Fasina, great. Hi to all. Okay, pyogenic and aseptic meningitis. Another one is chronic meningitis. Usually the pyogenic meningitis caused by bacteria. Usually. Aseptic meningitis usually caused by fungus and viruses, some fungus and some bacteria. Chronic mainly you can go for tuberculosis, some of the spirochetes, cryptococcus, those people they cause chronic. Okay. Next is in the meningitis we are again classifying based on the cells which is present in the CSF. One is called purulent meningitis. I'll summarize, don't worry. One is called purulent meningitis. So what is it? It contains polymorphonuclear cells, cells. Another one is lymphocytic meningitis. Many of the viruses, few of the bacteria, lymphocytic meningitis. Very few eosinophilic meningitis. Very few we have eosinophilic meningitis. Very few we have eosinophilic meningitis, mainly by parasites. Eosinophilic meningitis. Okay. Question is coming. Lokesh Jain. Yes. Yes, we have already told about parasite. See here. See here. When you see the etiological agents, bacteria, virus, fungi and parasites. We should not forget parasite because many things. Next is, so based on the cells which is present on the CSF, we can have purulent, lymphocytic and this one. So now I am summarizing the classification. Just remember, one is based on the structure, meninges, brain parenchyma and spinal cord. Another one is based on the etiological agent. We have bacteria, virus, parasite and fungus. Third one, based on the cells which is present on the CSF, we can get purulent, lymphocytic, eosinophilic. And another one based on the duration. One is called acute, another one is chronic. In the acute we have pyogenic as well as aseptic meningitis. So this is the simple way of classification. Just an overview. I am not going to in depth of each and every organism. It's just an overview. Okay. Hi, Dr. Nupur Sharma. Next is routes of spread. So these are all the agents, how they reach the site, routes of spread. If you know the basics, when you read the individual organism, easily you can correlate. I am integrating many things. Very common one is hematogenous spread via blood. Hematogenous spread. For example, pneumococci, meningococci, these are all usually hematogenous spread. And cryptococcus, I'll give example, meningococci. Meningococci is having hematogenous spread. Pneumococci. So they present in the blood, they travel in the blood, finally they cross the blood-brain barrier, they go to brain. And second one, direct spread. So what is it? The focus is near the brain. parameningeal structures like sinuses, otitis media, dental caries, those kind of condition. The real focus is somewhere. Okay, the real focus is somewhere. They will spread. They will go directly. Okay, for example, the infections from parameningeal structures. Parameningeal structures like dental caries, tooth, and ruptured skull, mainly otitis media. Classical example, Haemophilus influenza. We call it as unsafe ear. I'll teach you when that comes. Unsafe ear, because the Haemophilus influenza otitis media, easily it can go to brain, it causes meningitis. So otitis media. So these are the sites and some sinuses. So infection from the tooth, sinuses, otitis media, or ruptured skull, they easily they can cause infection. This is called direct spread. One more is iatrogenic, like lumbar puncture. Iatrogenic, lumbar puncture, unsterilized. Because of this procedure, possibilities of introducing infection. So these are all the different mode of spread. Okay. So now we are going to see meningitis. Now we are going to see meningitis, inflammation of the meninges. Okay, what they are going to ask, important, they will ask only what is the etiological agents and based on the age group. This is very, very peculiar, very, very notorious. Okay, see here. Usually neonates, birth to 28 days. Okay, birth to 7 days, it comes under early neonatal. More than that comes under late neonatal. So neonatal meningitis, the common causative agents. Remember these three and plus one. Okay, GBS, very important. Group B, beta hemolytic streptococci. Group B, beta hemolytic streptococci. Group B, beta hemolytic streptococci. We call it as GBS. Common name, Streptococcus agaricii. Next one is Escherichia coli, E. coli. You are aware of that. It's a common soil in the intestine. It is common soil in the intestine. Yes. Good evening, Dr. Neha Yadav, Dr. Shubhanki Chavan. Just I'm seeing the this thing. Okay, right. Third one is Listeria monocytogenes, very important pathogen. Listeria monocytogenes. Fourth one is Klebsiella pneumoniae. Klebsiella pneumoniae. These are all common neonates. Please remember, majority of the pathogens which causing meningitis are capsulated. They possess polysaccharide capsule. That is the main culprit. It's a thumb rule. Majority of the bacterial pathogen, they have polysaccharide capsule. That is the number one pathogen. And each organism, you need to have some clue. For example, group B beta hemolytic streptococci means it is positive for CAMP test. It's a clue. Suppose they are saying one organism gram positive cocci in chains, it exhibits CAM positive, then you think it is group B beta hemolytic streptococci. Suppose Listeria, easy, it exhibits a motility called tumbling motility. Tumbling motility. It's a gram positive rod, tumbling motility is E. coli. Okay. Klebsiella pneumoniae, this urease positive. Urease positive. Escherichia coli, it is lactose fermenter motile. So like that, each organism you have an idea, they will give some clue how to diagnose. Next is very important, more than 1 month to 5 years, up to 5 years. This is very important, my dears. This is very important. So in neonate, okay, less than 2 months, you can remember BEL, group B streptococcus, E. coli and Listeria. More than 5 years, more than up to 5 years, okay, the number 1, Haemophilus influenzae. Haemophilus influenzae. Next is Streptococcus pneumoniae. Next is Neisseria meningitis. Neisseria meningitis. Haemophilus influenzae, Streptococcus pneumoniae, and Neisseria meningitis. Up to 5 years. Please remember, only 3 organisms, but priority will be changed. Here the priority is Haemophilus influenzae. Number 1, Haemophilus influenzae. Number 2, Streptococcus pneumoniae. Next is Neisseria meningitis. This up to 5 years. Then above 5 years and adults up to 60 years. That means adolescents and adults more than 5 years to adults. You can take up to 55 years. The common is Streptococcus pneumoniae. See, the order is changing here. Streptococcus pneumoniae, Streptococcus pneumoniae. Next is Neisseria meningitis, we call it as meningococci. Neisseria, it's a gram-negative diplococci. Gram-negative diplococci, commonly seen in overcrowding and poor hygiene. Commonly seen in overcrowding and poor hygiene, and Haemophilus influenzae. Okay, Dr. Shubhangi Chavan asks her class is up to, it is 30 minutes class, 10 minutes MCQ discussion, 10 to 15 minutes. That's all. It's a demo class. Okay, right. Streptococcus pneumoniae, Neisseria, we call it as meningitis, we call it as meningococci, and Haemophilus influenzae. See the order, here it is SNH, here HSN. Order is changing. These 3 are common, but which is more common, that's important. That's important. And we can add in adolescents, tuberculosis also involved, Mycobacterium tuberculosis. Mycobacterium tuberculosis also there. More than 60 years, extremities of age, very common is Streptococcus pneumoniae. In the old age, Streptococcus pneumoniae. Very old age, Streptococcus pneumoniae. And in case of immunocompromised, for example HIV, immunocompromised, you can get all agents of normal, because if anything causes infection in immunocompetent, it also causes infection in immunocompromised. And please remember, apart from that, very notorious Pseudomonas. Pseudomonas, many Enterobacteriaceae, do not forget Pseudomonas, Enterobacteriaceae, Haemophilus influenzae. Apart from bacteria, notorious agent causing meningitis in HIV positive is Cryptococcus. Cryptococcus, very notorious, causing fungal meningitis in HIV positives. If we take bacteria, free living amoebas, you are aware of that, free living amoebas, they not only cause meningitis, they cause meningoencephalitis, like Acanthamoeba, Naegleria, they cause Acanthamoeba Naegleria, they cause meningoencephalitis. Then post-surgical procedure or trauma. Next is post-surgical procedure or trauma. Commonly you can get Staphylococcus aureus and Pseudomonas. Okay, any stunt, if persistent leakage in CSF, Streptococcus pneumoniae. These are all MCQs. Persistent leakage, Streptococcus pneumoniae. So just we have the etiological agent. In adolescent, most common is meningococci or pneumococci. The question from Naveen Kumar. Usually adolescent age group, Neisseria meningitis is common. If we come to adult, Streptococcus pneumoniae is common. But if we see the incidence, it's commonly seen in adults compared with adolescents. So if we divide, it's a good question. If we divide only for adolescent, Neisseria. Adult, Streptococcus pneumoniae. If we compare adults and adolescents, you can go for Streptococcus pneumoniae. Okay, good. Right. So now we got the etiological agent. Very simple. We saw the classification and we saw the mode of transmission, how it spreads. And next is we saw the etiological agents. Age group in neonates up to 5 years, children, adolescents, adults and old age, and other special conditions like immunocompromised, trauma, all those things. Next is, what are the clinical picture? Any meningitis, the common clinical pictures are fever, headache, altered sensorium, vomiting, confusion. These are the basic. Fever, headache, altered sensorium, vomiting. These are all the common complaints of any meningitis. These are the common thing. And you know the clinical examination also. Neck rigidity, okay, Kernig sign, everything you know. Okay, I don't want to go in depth. And once a patient comes with fever, headache, altered sensorium, vomiting, and history suggestive of meningitis, what you need to do? That is important. Lab diagnosis. Lab diagnosis, first and foremost, very simple, CSF analysis. CSF you can go for biochemical test and cells with opening pressure at the same of spinal tap. Second one is bacteriological. Second one is bacteriological examination. So if we take the CSF, we are going to see the glucose and you are going to see the proteins cells and pressure, opening pressure. In case of bacterial meningitis, drastic reduction in glucose, drastic increase in proteins, usually polymorphonuclear cells, and pressure will be increased. Very simple. In case of viral meningitis, glucose is usually normal, proteins are normal, you can get lymphocytes. Pressure usually normal or mildly increased, but usually normal. Next is in case of fungal meningitis, glucose is reduced, proteins are increased, you can get lymphocytes. And pressure will be increased. Opening pressure will be increased. This will give some clue to you. And mycobacterium. Glucose is decreased, proteins are mildly increased, lymphocyte and pressure will be increased. So once they gave this clue, you have an idea what is it. CSF examination says drastic reduction in glucose. Then you can think it is bacterial. Lymphocytes are seen, then you can say it may be viral or it may be due to fungal like conditions. Next is you do the gram stain. So for that you need to know the normal values. For example, glucose, okay, usually 60 to 80, protein up to 40. These are normal values. Cells usually polymorphonuclear cells 0 will be there usually. Lymphocytes will be up to 5 acceptable. So you know the normal values. Then you can say it is how much it is increased everything. Okay. Hi, Dr. Afin Muhammad, Dr. Istisha, how it is? Okay. Good. So gram stain will give some idea to you. Now it's okay. Gram stain will give an idea to you. Gram positive, gram negative, cocci, rod, yeast, everything we can say with the help of grams. Grams will give an idea to you. Next is antigen reduction. That's very easy test. Bedside. Bedside you can do. Just take the CSF, immediately you can do antigen screening. For 6 organisms by one test. One test, one plate, you can do 6 organisms. Is pneumococci, meningococci, Haemophilus influenzae, Group B streptococcus, Klebsiella pneumoniae, and Cryptococcus. Best test. You take the CSF, add 1 drop of CSF and 1 drop of the agent, do it like this. If agglutination comes, it's positive, that's all. So it's called CS meningitis panel test. Common agents causing meningitis. These 6 agents easily you can identify with the help of antigen reduction test. And management usually based on the organism. Suppose if you are getting the results delay, empirical you can start ceftriaxone, empirical. But best is do the culture sensitivity or identify the organism. Based on the organism you can do the treatment, that's best. But if you want to start the treatment, empirical is ceftriaxone. Because majority of the infections, ceftriaxone is the majority of the infections, ceftriaxone is the drug of choice. Majority of the meningitis. Apart from that, we can do other drugs. Okay, right. Suppose the people ask, what is the prophylactic drug for the contacts, carriers? What is the prophylactic drug for the contacts? Is number 1, ceftriaxone or ciprofloxacin and rifampicin. Okay. Rifampicin. Ceftriaxone, ciprofloxacin, rifampicin are the prophylactic drugs. And prevention is based on some of them have vaccines. For example, pneumococcus, meningococci, Haemophilus influenza. These people are having vaccines. Cryptococcus, they have prophylactic drugs like fluconazole, like we have the prophylactic drugs. So some of them are having vaccines, some may not have the vaccines. Okay, so this is the just overview of meningitis. Just overview. If we know the organisms, we are integrating the organisms. Meningitis caused by different organisms. Okay, and now the time is 5:32. We are going for some questions. What I taught in the 30 minutes. Try to answer some questions. This is a new pattern. NEET or any set. Next, have this pattern only nowadays. Clinical scenario. Integrating medicine and micro together. 18-year-old girl staying in college dormitory. Every word is important. Every word will give some clue to you. They will direct you to some organism. College dormitory brought to the casualty with history of headache and lethargy for 1 day duration. Fever and vomiting present since last night. No significant medical history. So fever, lethargy, vomiting. She responds only to deep painful stimuli. So there is some problem in the nervous system. Physical examination shows resistant to passive neck flexion and several petechiae in lower limbs. Yes, which bacterial meningitis we are having petechial hemorrhage? That's the clue. That is usually a CSF. I will come back. CSF analysis, glucose very low amount, proteins are highly increased, leukocytes, neutrophils are there 85%. Gram stain shows here. Gram negative diplococci. Gram negative diplococci. Gram negative diplococci. It's not a regular class, it's demo. It's demo. Okay. Dr. Divya? Yes. Next is, see the gram stain. We have pus cells, polymorphic cells, and gram negative diplococci from CSF. You can vote for meningococcal meningitis, no doubt on it. Because it's a bacterial meningitis, glucose is reduced, protein is increased, polymorphonuclear, and petechiae, rash with petechiae. Pneumococci is gram positive cocci. Other findings are same, it won't produce rash. Arboviral, you cannot get the bacteria and it causes aseptic meningitis. Acute Lyme disease. Acute Lyme disease. It also presents with meningitis, but presentation may not be presents with aseptic meningitis, and possibly you can demonstrate the organism not by gram stain, by Giemsa stain, Borrelia burgdorferi. So you need to, very good. Many people answered nicely. It's meningococcal meningitis. Next is, with the continuity of the previous question, in the previous case, that 18-year lady, dormitory, she developed the disease. Choose the correct community contacts are likely to need prophylaxis. Very practical question. We are getting the question like this in future. Those who ate lunch with the index case that day, or those who attended a party with index case on evening before, or those who travelled on the bus next to the index case that day, those who slept in the dormitory with the index case on a field trip last week. So I already told, poor hygiene, overcrowding, mode of transmission, inhalation. This organism goes and settle in the nasopharynx, then it multiply, colonize, then in the bloodstream it go to brain. So the close contacts needed vaccination, but whom? Very important. Whom spend more time? That is important. Whom spend more time with the index case need to be vaccinated. Among the choices, ate lunch means 20 minutes, 30 minutes. Party 1 or 2 hours. Traveled bus next to the index case, half an hour to 1 hour, we don't know exactly. But the who slept in the dormitory almost 6 to 7 hours, they have the close contact. They have the close contact. So those people need vaccination. Those people need prophylaxis. D. Very good. Very good. Dr. Shumeda, Dr. Rana Patyasha, Amrish Yadav, everybody answered beautifully. Beautifully. Great. Next question. Continue. Story not yet over. How could this infection in this case have best been prevented? How we are going to prevent this? Number 1, improved sanitation within the dormitory. Number 2, hand washing. Yes, now hand washing is universal after COVID-19. Hand washing with sanitation gel. And prophylactic ribavirin vaccination. Okay, listen to me carefully. Improved sanitation within the dormitory may not be helpful. You know why? The mode of transmission is inhalation. Hand washing and use of sanitation gel may prevent other infection, not this infection, because this infection is inhalation. So respiratory hygiene is needed, not hand sanitation. Prophylactic rifampicin is good. It is ribavirin. They are confusing you. See the word ribavirin. Ribavirin is antiviral. Rifampicin or antibacterial. So remove that. So best is vaccination. We have tetravalent vaccine. ACWY vaccine. We have tetravalent vaccine. Meningococcal vaccine. So you need to know each and everything. So first we diagnose its meningococcal meningitis. Number 2, we need to know whom eligible for vaccination, who spend more time. Number 3, how to prevent the disease. Best is vaccination. Okay, hand washing will prevent some other infections, even COVID-19. MRSA, all by hand washing is the best method. Right. Next, improved sanitation will prevent foodborne illness, many other illness. Okay, great. So answer is D. Oh, everybody answered beautifully. Good. Dr. Tu, Dr. Baby Kumari, Kaushik, Nupur, Amrish, Rutu, Virendra, everybody there. Great. I'm happy. 2 more questions. Because questions are huge, you need to have the patience to read and understand, and you need to respond very fast. Okay, the questions are big, you need to respond on time. Many people say I am not able to read the question and finish only 50%. Not like that. In practice. 62-year-old old man presents with outpatient clinic with 3-week history of general malaise. More specifically, last week he has noticed throbbing headache, lost appetite. He feels that left side of the body is weak. Headache, weakness, no energy. He has vomited. That's all. Headache, weakness, vomited. 2 occasions. He smokes 10 cigarettes, consumes 80 units of alcohol per day. He lives on his own at home. Usually manages to cope well. These are all unwanted points. On examination, he has temperature, high temperature, pulse rate and blood pressure little high. A gram stain shown, made a sample CSF shown in the image. What is the most important virulent factor of the condition? See the gram stain. He is an old man having meningitis-like features. What will be the organism? Extremities of age. It's a gram-positive diplococci. See, gram-positive diplococci, pass, almost flame shape. Yes, this is pneumococci. Streptococcus pneumoniae. If you come to conclusion, it's Streptococcus pneumoniae. Next, you need to know what is the important virulent factor for pneumococci. I already told the NHS organism, Neisseria meningitidis, Haemophilus influenzae, Streptococcus pneumoniae and Cryptococcus, Klebsiella pneumoniae. The major virulent factor is capsule, polysaccharide capsule. That is important because we are using polysaccharide capsule to produce vaccines. Polysaccharide capsule vaccine. Okay, Exotoxin A usually Pseudomonas will produce. Polypeptide capsule present in Bacillus anthracis. And lecithinase produced by Clostridium perfringens. Clostridium perfringens. Okay, so you need to segment, you need to dissect and read microbiology and infectious diseases. Okay, right. You need to know the organism, how it caused the disease, how to diagnose, what is the management. You may have some idea in your mind. Template, I used to tell always, make a template. Meningitis, on template should come to your mind. So what are the clinical finding? What are the laboratory finding? What is the etiological agent? Based on the etiological agent, one more template. That etiological agent, what is the lab diagnosis, confirmatory diagnosis, what is the drug of choice, other points. Okay, right. Class Robinson class started on 5 o'clock sharply. Next is final question. Yeah. A 35-week pregnant female recalled flu-like illness 2 days prior to delivery. She was treated with peripartum sepsis and her newborn child was born in poor condition and admitted to the neonatal intensive care department. Blood cultures, including CSF, grew the organism which exhibits tumbling motility. That's all, game over. So you should know it is a neonatal meningitis. In the neonatal meningitis, what are the common causative agents? And the organism which exhibits tumbling motility from CSF, you can vote for Listeria monocytogenes because group B Streptococcus non-motile, Klebsiella non-motile, E. coli motile. It is gram negative. But it won't exhibit tumbling motility. Tumbling or somersault motility exhibited by Listeria. Drug of choice for Listeria is ampicillin. See, Listeria infection, 1 or 2 cases may occur in old age, but very common is Streptococcus pneumoniae. Always exceptions are there. We may get 1 or 2 cases of Listeria in old age, but see, most common is Streptococcus pneumoniae. Especially people without spleen, asplenia, splenectomy, extremities of age, chronic smokers and alcoholics. You think of Streptococcus pneumoniae. So each organism you may have idea. That's the clue. If they give the clue, is old age, chronic smoker, then you can think of Streptococcus pneumoniae. But if the organism exhibits tumbling motility, then you should go for Listeria. So you need to take diversion based on your existing knowledge. Read well, have a base understanding. Based on your understanding, whatever the question comes as a twist, you can twist the question. Okay, right, exactly now the time is 5:45. So I'm winding up the class. The people who want to join DAM's Ultimate Live app course, that's unique in nature because every app is pre-recorded sessions. Here there is no pre-recorded and live. Both people are talking. Okay. See, sir, Listeria most common, not Listeria. Amir Shato asked one question. Dr. Sir, Listeria is most commonly seen in air condition. No dear, that is not Listeria. That is Legionella. Causes air condition. It causes atypical pneumonia. Legionella. Listeria, tongue twisting. No, it is Legionella. So directly you can ask and you can get the answers. Got it? This is for Dr. Amish Yadav. Air condition is Legionella. So if you like the class, if you join the DAM's Ultimate Live app course, you may get the discount if you mention the following code in your coupon. That is, my name is Dr. J. Suryakumar, MED 207 is the code. This is the code. If you have any doubt on the course also, you can ask. This is unique, integrated, and suppose if you miss the class on live, it will be available on recorded format to you. So two things. One thing, you can live, because live is always best. Whatever doubt you comes, immediately you can ask, immediately you can get clarification now itself. Otherwise, if you type, if you think, you contact faculty, is difficult. Suppose we miss something, and the same thing available in pre-recorded class also. Okay, if anybody wants to join, you can use the code Dr. JS Med 207. You may get up to 10% discount. You may get up to 10% discount by using this referral code. Use it as a referral code. Okay. Now the time is 5:47. I took 2 minutes extra. 5:45 is the time. 5 to 5:45. Thank you very much. God bless you. See you soon in the ultimate live app class. Thank you very much. No problem, Amrish. Oh, no problem. We are here to clear your confusions. Good evening, Dr. Madhushri. Any other doubts? I can extend off the record. Class is over. If you have any other doubt, you can ask 1 or 2 questions. I'm expecting. Thank you, Kaushik. Shashwat Panda. Great. DAMS is a very good platform. Facebook is there, eMedicos is there. You can contact the faculties, integrated. DBT is available for you. Everybody hear about DBT, ask questions, they will tell. Okay. And we have an excellent team to serve you and make your dreams true.